Okay, welcome everyone, and thank you Dr. Voda and Sarah for inviting me to be here, as well as Dr. Connolly for giving us a great introduction to some of the genetics of what I'm going to discuss today. I will say I do not have the new nomenclature on my slides. I still will be the older nomenclature when I'm referring to things, but do know that that's changing. Okay, so I'm going to be speaking on the genetics of limb-girdle muscular dystrophy. So back to the basics, genetics 101. Again, Dr. Connolly brushed on this a little bit, and I know it's a little small for everyone, but we have here the cell, and inside the nucleus, we have all of our chromosomes. We all have 23 pairs, one from mom, one from dad, of every chromosome. And then on these chromosomes is the DNA, and then within the DNA are all the genes. That LCGC, like Dr. Connolly said, is what our genetic code is made up of, and this gets translated into protein that then makes our body work. Not only our muscles, our nerves, but everything in our body is from our genetic information. So the gene, I like to use a little bit of a train analogy here. So we've got the gene is the whole of the train, but within it we have the carts or the exons that carry most of our genetic information, but the introns are important. And then the promoter of the gene, the front of the train that makes the gene able to work properly. Okay, so as we were discussing, the normal gene means we get normal protein, but when there's changes within these genes, or there's mutations, variants, whatever word you want to use for it, either an abnormal protein is created or no protein at all is created. So genetic disorders are common. 53 out of 1,000 individuals will have a disease with an important genetic component before the age of 25. This is speaking genetic disorders in broad term. So 70% of pediatric inpatients have an underlying disorder with a significant genetic component. 3% of the general population will have an intellectual disability that has a genetic component. And 1 to 2% of US children have autism spectrum disorder, and 5 to 10% of cancer is due to an inherited genetic defect. So muscle diseases are just a small subset of our genetic disorders. So limb-girdle muscular dystrophy, that very small subset of all genetic disorders, is a diverse group of muscle disorders with many subtypes, as Dr. Connolly discussed, and you'll continue to hear throughout the day today, that are characterized by the disease gene as well as the inheritance pattern of it. Symptoms usually include weakness and atrophy of the proximal muscles around the hips and the shoulder. So same picture that we saw on the other slide. Oh, there we go. Over here, the shoulder, as well as the hip area, the muscles. And age and speed, as well as severity of disease progression varies. Again, as we saw on the last slide, variable is the word for this disease, and the age of presentation as well as severity. So genetic testing, a quick overview on that. I like to stress this is not just a blood test. This is not just one of those tests you go to your doctor, you get without having more of a discussion of what this could mean for you. And that's because genetic tests don't just affect one individual. It affects an entire family. When a genetic diagnosis is found, it's not only the one patient sitting in front of me, but it's children of this individual, it's brothers and sisters, as well as possibly even parents. So it's not just one individual. And it can also, when we have a genetic disease in the family, it can help, it can predict who might have symptoms. So genetic testing is available even in individuals that haven't had symptoms yet to know whether they may develop symptoms. And then there are issues that can vary depending on the reason for genetic testing. There's a lot of different complications with different genetic disorders, and meeting with a genetic counselor can help discuss what these issues could be and whether you're one of those individuals that might need a little bit more support through the process or more of a discussion prior to making the decision to proceed with genetic testing. So possible results. This is another reason that this genetic testing is not just a blood draw. It is never just a clear yes or no. We do have other results that we can get. So as you can see here, we do have the positive, negative result. Those are wonderful. Those are great. Positive result, we get a clear answer. This is what it is. This is the specific genetic change that's causing your disease. And we have an answer and we have something that we can use to test other family members. Negative, a little more frustrating for us than a positive result because we now know you have a diagnosis, but we don't know why you have these muscle concerns. And then what I describe as even more frustrating is our variants of uncertain significance. So these are changes in the gene that we don't know what they mean right now. They've never been seen in any other patients, so it's possible that they could cause limb-girdle muscular dystrophy, but it's also possible that they are just benign changes. So we actually know in genetics that 85% of the time when a variant of uncertain significance gets reported out, 85% of the time it is benign. It's a random change in your DNA that does not create an abnormal protein, does not create muscle disease. But the lab is reporting these variants of uncertain significance out to us because there is that 15% of the time that we have actually found the cause, and it's just an extremely rare cause. And then incidental findings. These are not necessarily coming back as often as the other three results, but there's something where we might be we're looking to see if we can find a diagnosis for a patient, but we're not finding a specific diagnosis, we're finding that they're a carrier for something, meaning it's not enough for them to have experienced symptoms of the disease, but if their partner is a carrier of the same thing, there's risk to future generations for that specific disorder. So that's one example of an incidental finding that can come back from a genetic test. So, reiterate, a genetic test is not just a blood test. Because of these complicated results, meeting with a genetic counselor or someone that's familiar with genetic testing is always recommended when pursuing genetic testing. Okay, so I have a little bit different depiction of when errors go on, and so you might, I don't know if you're able to actually see this, but we've got the original here that says, "I'll be by the lake." And then when we have a point mutation or a change in just one single letter, the first one is I'll be by THW Lake. We all have spell check errors. Is this enough to make us not know what that sentence is? Maybe, maybe not. We might be able to discern that it still means I'll be by the lake. So that might be what we call a variant of uncertain significance. Is it enough to change the sentence? We're not sure. But then the second example of a point mutation is that L in lake is changed to a C, and then the sentence reads, I'll be by the cake. This is completely different and no longer means the exact same thing, and so this would create an abnormal protein. And then nonsense is taking away half of the sentence, again, creating an abnormal protein. You no longer know where this person is going to be. I'll be by. And then a frame shift that Dr. Connolly so well described. This is nonsense. We have no idea what this could possibly mean, and it's creating an abnormal protein. Okay, so briefly, there are many different types of genetic tests. There's biochemical testing that can help. There's karyotype, which is looking at the chromosomes from a very big picture, and it's seeing how many chromosomes, are there any changes from this very big picture, as well as FISH, chromosomal microarray, repeat primed PCR for expanded nucleotide repeats, mutation screening or sequencing, deletion duplication, and then whole exome genome sequencing. I just put these all here to say that there are so many different genetic tests that can be sent, but for limb-girdle muscular dystrophy, there's specific tests that we can send, and these tend to fall into the mutation screening, sequencing, del-dupe, as well as sometimes a whole exome or whole genome sequencing if we're not able to find with a limb-girdle panel what we were looking for. So genetic counseling. What's my role in all of this? This is a quote that's taken from our National Society of Genetic Counselors. I'm not going to read it to you, but pretty much what my job, my role is to help facilitate the genetic testing, is to take the time to meet with all of you, discuss through, is this something that would benefit you? Would it be beneficial? Who would it impact in your family? What type of things might it change for you? As well as helping you understand those possible results. Discuss through what the options are, as well as when that report's sitting in front of me, walking you through, because most of the time it is not an easy to understand language, even for some of us in the field. So my role is more that facilitator, making sure you all understand what's coming back on genetic testing. So I've got a little bit, we had a very similar slide actually from Dr. Connolly in terms of the similarities between all the limb-girdle muscular dystrophies, because we have so many different ones. The inheritance is always autosomal. That's meaning that it's in your cells, of all of your cells, and it's not on the sex chromosome. It's not on your X or Y chromosome, meaning that both males and females can have this disorder equally. The musculature, as we've already discussed, is the shoulder and pelvic girdle. Limb is mostly proximal instead of distal. The CK, which is a lab that's normally sent, is typically elevated. And then dystrophic on those biopsies that we already saw, that's typically what's seen with all of the limb-girdle muscular dystrophies. And then what is causing it? The etiology of this this disorder is typically muscle cell damage and muscle fiber degeneration. But what are the differences? So age of onset, pretty much this slide, what this slide means is it's variable. So age of onset, early childhood to adulthood, the progression can be slow to rapid. The serum CK is elevated, but for the dominant forms is typically less elevated than with the recessive forms, but can be all around the same area. Genes, I have 31 here, might be a little off in that. And then possible disease mechanisms, the protein aggregation, defects in the membrane repair, dissociation of the sarcomere, as well as errors of glycosylation of the alpha dystroglycan. So we've already briefly discussed this as well. There's the different inheritance patterns. So the way the disorders are classified is whether it's in the autosomal dominant or the autosomal recessive pattern. Along with this one or two, a letter is assigned to each type depending on the order of discovery. Again, we already discussed the new nomenclature of what that will be as well. So autosomal dominant, I included a picture here to just help us walk through a little bit better on what this looks like. So autosomal dominant, we have father has the condition, mother does not. So down below you can see the check mark is a working gene, the X is a non-working. So dad has one working, one non. Mom has both working copies. So for mom, all she can pass on is the working copy to all kids. So if you follow those lines, I'll try to come over here and do this one as well. Working copy, we've got the working as well as non-working copy. And so what we see that 50% does not come from mom. We can pretty much ignore what hers is because there's both working. But it comes from dad can 50% of the time pass on that normal copy, and 50% of the time pass on that abnormal copy. So we have on the left 2 children that do not have the disorder because they got dad's working copy of the gene, and then we have on the right the abnormal working he passed on the abnormal copy, the non-working gene, and these children have the disorder. This 50% chance happens with each individual pregnancy. So a lot of patients I will see, and they'll say, well, I have 4 kids, so that means 2 of mine definitely have it, 2 of mine don't. This is not the case. It's that flip of the coin every single pregnancy. So I've seen families where all 4 children got very lucky and do not have the disorder. I've also seen families where all 4 children, unfortunately, inherited the non-working copy and do have the disorder, and everything in between for that. Okay. And so the autosomal dominant types of limb girdle I just put here, all from A to F, 1A to 1F, and the specific gene that's associated with them. And then autosomal recessive inheritance. This means that mom and dad are both carriers. Carriers mean that they can have one abnormal copy of the gene, but they do not show symptoms. That one working copy of the gene is enough to make it so that they can function normally and wouldn't know that they're even carriers unless testing was done for some other reason, or they had a child with the disorder. So what we have is, again, the check mark, meaning the working copy, and then the X, meaning the non-working. So they both have a check and an X, and then they both have a 50% chance of passing each one on, which then works down into 75% of the time, the children will have at least one working copy, meaning they do not have the disorder. But 25% of the time, the child will inherit both abnormal copies from the parents, meaning they will develop symptoms of the disorder. With that said, as you can see in the middle here, there are 2 out of the 4 that have one abnormal copy. That means one of the kids over here does not have, or has both working copies. They will never be able to pass on an abnormal working copy of it, and are not carriers of the disorder, but the 2 in the middle are carriers, and so if their partner was also a carrier, then it starts right back at the top of both mom and dad being carriers, and that continued 25% risk of the disorder. But they, in the middle, would never develop symptoms of the disease. Okay?
Question, sorry.
Yeah.
So if you go back a slide.
Yep.
There's one more, sorry.
Yep. Oh, sorry, wrong way.
So if there's one of each
Mm-hmm.
from the, I'm sorry, it was the other.
This one? Or?
The dominant, okay.
Yes.
So with all of them, would they just be carriers?
None of the.
They've got one normal and one.
So this is a different inheritance pattern of that only one gene is needed in order for disease to occur. So you're right, if we were talking the autosomal recessive, they would just be carriers here. Let's say that we have this of dad's a carrier, mom is not. Yes.
Yeah, no, I was just comparing those two.
Yep, nope, they're completely different inheritance patterns of it. And yes.
So in this, if mom is a carrier, dad is not, the same way it works?
So if we go to the autosomal recessive and mom is a carrier but dad is not, then dad would have a check mark here. All kids would have a 50% risk of being a carrier, but they would not have a risk of having disease because there would not be a possible way of getting 2 non-working copies with the autosomal recessive. Does that make sense? Okay, great. Any other questions before I move on? Yes.
In this scenario,
Yep.
how far out should genetic testing go in your family?
Yeah, that's a great question. So the recommendation would be anyone that wants to know. One of those, let's say, okay, so we've got mom and dad. Mom and dad both have siblings that are, let's assume they're of family planning age, and they have a possibility of being a carrier because we know mom and dad are. So if the siblings on both sides wanted to be tested to know whether they're carriers, they could. If they were carriers, then we could test their partners to know if they don't have a gene change in that exact same gene, which is a very low likelihood, but obviously happens because we see these diseases occur. We could figure out whether the partner also was a carrier and then know whether there was a risk in the future generations or not. So there wouldn't be a reason to do testing for the partner, though, if the sibling was found to not be a carrier, because it wouldn't matter. Okay.
But all of this is based on knowing which genes are involved.
Correct. Yes. Yep. Depending on which gene it is, tells us which type of inheritance it is for the.
If it has not been determined which gene is involved, then there's no genetic counseling, basically.
There can be genetic counseling, but there's a lot less definitive information I can give you. Yes, correct. Yep. Yes.
Okay, so in the first example,
Yep.
the difference is that in that example, the father is symptomatic.
Yes, correct.
So if you are symptomatic, then you are more likely to pass on the disorder to your children than if you're not symptomatic.
If you have the dominant form of the disorder. So again, as we were saying over here, if we don't know what genetics there is associated with it, what gene change there is, if you're symptomatic, I could say that it depends on whether your partner is a carrier or not, or there is a 50% chance. So that it's a lot less information I have to give you if we don't know the genetic change specifically.
Right, but if there's family history, then you know more, even though you don't know the cause.
Correct, yes. If there's a family history and I'm looking at it, and we'll actually get to a few case examples where I'll show you my thoughts and my drawn out pedigrees and all of that. But if there's a family history and I'm seeing it in multiple generations, the likelihood is it's an autosomal dominant pattern, and we're talking this rather than the autosomal recessive pattern that we see here. Okay? One more question and then I'll go back to this.
So in an autosomal dominant father,
Yep.
I assume half of the sperm carry the gene and the other half don't? Is that the way it works? So,
That's our assumption.
and so then will those that carry the gene be less likely to fertilize the egg? Do they have reduced motility?
That's a great question. I don't believe so. Nope. Our assumption is that it really doesn't change it, and there's no, and again, we say the 50-50 for that exact reason. If it was a female, we'd expect that 50% of her eggs. Yes. Okay, great. So I'm going to go back to this. I do have time, hopefully at the end, to do more questions. I will say, unfortunately, I have to leave immediately after my talk, but you can talk with anyone, Sarah, Dr. Voda, about getting my contact information if you're not able to catch me after my talk and do have follow-up questions. Okay, so I'm going to move on. So the different types, again, as we already talked about in Dr. Connolly's talk, there's a lot more autosomal recessive types of limb-girdle, and these are all the different types and the different genes associated with it that I actually got directly from the MDA website. So prevalence, again, pretty small here for us to see. This is the prevalence of the limb-girdle muscular dystrophy types in the United States. So we have here 30% are caused by this CAPN3 gene, and then the percentages decrease significantly from there. This, of course, as you can tell, are not the 30-some different types. It just means that that percentage is much lower than the 2% that they're reporting here for the SGCD gene. But the most common subtypes are these listed here, the 1A, the 1B, 1C, 1E, and 2R, 2A, 2B, 2C, D, E, F, 2G, 2I, K, M, N, O, P, T, U, 2J, and 2L. And then I have denoted down here with the asterisks on these are the ones that are most likely to present in childhood. As well as the little R circle here is the cardiac involvement is common with these specific ones. But again, I'd like to stress it's variable with every single one of these types. We don't know definite answers on any of it. Okay, so again, more on the importance of genetic testing. It can provide an accurate diagnosis for us. Not only, as we've already stressed, can it help give us an idea of that exact inheritance pattern, so what's the risk for other family members, but it can give us a reason for why you're having these symptoms. And it ends, I like to use the phrase, the diagnostic odyssey. So many of my patients are going through this process of, I have these symptoms, but why do I have these symptoms? So doing genetic testing and finding an accurate diagnosis can end that for us. As well as it avoids the inappropriate treatments. Is the specific limb girdle that you have associated with cardiac or respiratory involvement? If it's not, the need to see a cardiologist is much lower than the other types. And then efficient uses of resources and different things that you might need. As well as management and surveillance for those affected. Again, do you need to see a cardiologist with the specific type of limb girdle or not? Identifying pre-symptomatic individuals. Again, which type of inheritance pattern is it? Who's at risk? Are they at risk of being carriers, or are they at risk of having symptoms of the disease? Discussing reproductive risk, having that conversation, the autosomal recessive pattern. Is a sibling a carrier? If they are, is that partner also a carrier? Is there that 25% risk of having a child with limb girdle muscular dystrophy? Talking through the different options that are available, doing prenatal genetic testing, as well as there is pre-implantation genetic diagnosis, fancy way, it's PGD for short, and this is an IVF way of doing it, testing the embryos and seeing whether they will have limb girdle or not. So there's options available, and knowing the specific diagnosis is a way for me as a genetic counselor to be able to talk to you about these different options that are available. And then opens up research opportunities as well, knowing a specific diagnosis. So management with this, just like I already briefly mentioned, whether there's cardiac involvement or respiratory involvement, or there's risk for contractures, different subtypes have these different risks. And so knowing the specific genetic diagnosis is an ability for us to know what providers you need to see and making sure you're getting the best care possible. Okay, management. Unfortunately, at this time, there's no specific treatment if we know your specific type. We're still going to manage you exactly the same in terms of the muscle weakness, besides sending you to possibly other providers. But it can be tailored to each individual specific type of limb girdle muscular dystrophy to improve the quality of life. Always recommend seeing a multidisciplinary clinic team because they have all of the resources in order to help you to make sure that you're improving your quality of life and getting the best help needed, including providing assistive devices as well as appropriate therapy and exercises. In terms of research, it's an exciting time right now to be in muscular dystrophies, and many studies are specific to the cause of the patient's limb girdle muscular dystrophy. So a lot of the studies are specific to that one genetic cause. Right now, I did a search on May 15th on clinicaltrials.gov, and there were 30 clinical trials that were found there when I searched limb girdle muscular dystrophy. This, let me say, is from the not yet recruited to the complete, so they weren't all ones that were enrolling, but it at least gave us a list to know what research was out there and where exactly it was happening. And the best way to know whether you're eligible for these trials is to discuss it with your doctors. They're going to know the best on whether you're eligible or not for it. But a couple different sites there are. Clinicaltrials.gov is one that I use all the time. Again, that's the search I did. As well as the MDA has a clinical trials finder right on their website that you can go to as well. So I'll get to my cases, and then hopefully I'll have a little bit of time for questions. So my first case is a 49-year-old female who presented with weakness in her legs when climbing stairs, as well as getting up from the seated position in her early 20s. So had symptoms for over 20 years. Weakness in the upper extremities did later develop. Her CK was 202, EMG was suggestive of chronic myopathic process, and the muscle biopsies showed non-inflammatory myopathy with no abnormal staining. So, did I miss? Oh, there we go. I skipped over a slide. I knew I had this. So this is the pedigree that I drew out when I met with her. And so what we see down here, sorry, this green circle right there, and I'll go over here. The green circle right there, that's the patient that I saw. And you've got shading in on people I've now diagnosed. So I gave a little hint here that she's been diagnosed, as well as her son. She has 3 sons, and she has 3 siblings that were all affected, as well as 4 siblings that she doesn't think have similar concerns. And then on her dad's side of the family, it's a very strong family history. So dad had similar myopathy muscle concerns, as well as 3 of his brothers, as well as his grandfather. And again, for this one over here, this is dad here, dad's 3 brothers, and dad's grandfather, and her 3 siblings with that. Okay, so there's her. And then I sent genetic testing in 2016, which did identify a disease-causing variant in the LMNA gene. I wrote the specific variant that was found right underneath, but this gene is associated with limb-girdle muscular dystrophy type 1B. It generally presents with the onset of the hip girdle muscle weakness before 20 and slowly progresses to the shoulder girdle muscular weakness. And other symptoms include joint contractures as well as cardiac symptoms. So this allowed us to refer the patient to cardiology. Thankfully, she does not currently have any cardiac concerns, but this way we're making sure to follow her just in case they do develop. But you can see that her presentation was pretty classic to what we know as the overarching for limb-girdle type 1B, except that she might have been just a little later in onset, a little after the age of 20. Okay, so we'll move on to case number 2. This pedigree is a lot less striking than the other one. We only see one individual with symptoms. So I've got this one right here. She's a 22-year-old, and she's got a clinical diagnosis of limb-girdle muscular dystrophy. And mom, dad, she has no siblings, but mom, dad's siblings and nieces and nephews, all healthy. Again, we got the red circle here, that's who's affected and seen by me, and no siblings, no children yet, and no one else in the family affected. Okay, so she presented first as a 19-year-old who had experienced leg weakness since around the age of 13. It was difficult to jump like other children. She had difficulty climbing stairs, getting up from sitting or the lying position, had issues with running, and reported gradual progression of the symptoms over the past 6 years when I first saw her. Muscle biopsy showed consistent findings of muscular dystrophy, and the dystrophin and cavelin 3 stains had intact membrane staining and cytoplasmic staining. And then, yeah, most of the other stainings were all normal. So we sent a limb-girdle muscular dystrophy panel in 2015. It identified 2 variants or mutations in the CAPN3 gene. But here's where we get a little complicated. One was called a pathogenic or disease-causing variant, and the other one was called a variant of unknown significance. So I will say we've gone back, and I just double-checked, I want to say 3 or 4 months ago with this patient. The second variant is still identified as a variant of unknown significance. So we think we have a diagnosis for her because it fits. It sounds right. It's a gene that we would expect 2 different changes in, but it can't be a definite diagnosis. So this is the most common form of limb-girdle muscular dystrophy. It's type 1A, and it's typically normal without cardiac involvement. Oops. So with this patient, unfortunately, we haven't been able to do parental testing. So the one thing that we haven't determined from this genetic testing is both of these changes in the exact same gene. meaning that if we looked at her other gene, is that other gene normal? And then we wouldn't expect it. Or are they in both of the different genes? And so we haven't been able to do parental testing, so we haven't been able to determine that, yes, one was inherited from mom, one was inherited from dad, and then our suspicion would be even more so that this is actually a diagnosis for her, even though the lab still calls it a variant of unknown significance. So we're calling her a limb-girdle type 1 or 2A right now, but unfortunately it's not a definitive diagnosis at this time. And then my third and final case, you'll see, I'm going to point over here first. You'll see the patient that I saw right here with symptoms. He's got two adopted, all three of his children are adopted, does have a brother, and then we have some non-specific family history over here. Nothing exactly the same as his presentation. We do have, mom had some muscle weakness and scoliosis, but was that because of other things that were going on for her? No specific diagnosis was given. So he was a 59-year-old male with, again, progressive proximal more than distal weakness that presented in about 2004. He also had scapular winging. The muscle biopsy in 2004 showed myopathy as well as near loss of the caveolin 3 immunoreactivity. The custom muscular dystrophy genetic panel was sent in 2015 that included 40 genes. And we came back with two variants of unknown significance in the COL6A3 and the PLEC gene. Doing research, looking at these variants of uncertain significance, this does not look like an answer. Neither one of these genes look like an answer for this patient. And so he now has the clinical diagnosis of limb-girdle muscular dystrophy, but unfortunately we do not know a genetic cause. So we're back to saying, we think this is likely genetic. We don't know what the cause is right now, so we can't tell you the risk for your other family members, or have more specific information on whether you need to see cardiology or anything like that. So my case has helped highlight that genetic testing does not always give us an exact diagnosis or an exact answer. So it's a little bit more complicated, but there are benefits, and please meet with a genetic counselor so that we can help walk you through this process. And so any more questions? I believe, do I have time?
We can do one or two more questions, but first, thank you. That was it.
Okay.
One or two more questions?
Mm-hmm.
So when I first got diagnosed, I had the panel through the Jane Foundation.
Mm-hmm.
And then, because one of my sisters was diagnosed, I was part of a sub-panel for her. But that was a few years ago. Do people go back and look at this stuff? I mean, I talked to a genetic counselor through Emory on the first panel.
Mm-hmm.
And I met with the geneticist at University of Rochester. But I really haven't met with or talked to any of them since.
No, that's a wonderful question. Yes. We're learning a lot more. As we've all alluded to, there's a lot more types, and our testing is getting better. So I typically recommend every 2 to 3 years to bring up the possibility of doing genetic testing, because your doctor might say, actually, no, there's not any additional information available, but there might be. So talk to your doctor and see whether they think, based off of what panel you had, whether there are new genes that new testing would be able to look at. Yep.
And one more question.
For the genetic testing, are there certain centers that we would have to go to, or is every major teaching hospital have something available like that, or how do you find that out?
That's a great question. So I would go through your doctor on their recommendation. Some doctors, neurologists will send testing themselves. Again, I'm a little biased because I recommend seeing genetic counselor and having that discussion. So there is a site, the National Society of Genetic Counselors, where you can put in your location, your city, and it'll show you the closest genetic counselor to you. And so they're able to, that way you're able to contact them directly and see if this might be something that they would see you and send testing for.
Are most genetic counselors somewhat aware of the limb-girdle?
Yes. So So it depends on specialties. So I am a neurology-specific genetic counselor, so I am very well versed on this. Not everyone is that well versed. But if you're looking at someone that is in a general genetics clinic, an adult genetics clinic, or pediatric, they will have knowledge of the limb-girdle muscular dystrophies. Yep. Okay. Yep.
So my question is similar to his. I was diagnosed in 2007, and the results, they found the exact, like, positive for two mutations, and they, like, listed the gene and the CAP1-3.
Yep.
So is there any, like, and my sisters have been screened as well, like, with that panel, and have come back either positive or negative. Is there any reason, like, have there been any more developments in 2007, was a while ago?
Mm-hmm.
But should I even, I mean, is this sufficient, or should I?
So that's a great question. And the difference here is knowing and not knowing your genetic mutation. So you know it. I would say there is no need to do any additional genetic testing. It would just be a cost that doesn't need to be taken on. You know your genetic diagnosis, and so additional testing will likely come back negative for you.
Okay.
Yep. Okay, great. Well, thank you, everyone. Again, I'm unfortunately going to have to leave, but please reach out to Dr. Voda or Sarah for my contact information if you do have any additional questions.